السلام عليكم ورحمة الله وبركاته. طلاب المرحلة الخامسة. We'll continue our lecture on rheumatology. Our daily subject is septic arthritis. Septic arthritis occurs when there is invasion of infectious agent into the joint and joint tissue. Septic arthritis usually very rapid and destructive joint process. It has incidence of about 2 to 10 per 100,000, but this rate will increase several fold if the patient has underlying joint process like previous trauma, previous infection, or a joint destruction by chronic process like rheumatoid arthritis. Despite our efforts for early recognition and specific antimicrobial therapy, the mortality rate of septic arthritis is still high of about 10% despite antibiotic use. The most risk factor for development of septic arthritis is old age, which is also the most common cause for mortality. But there are a lot of other factors that increase the risk of acquiring septic arthritis, including pre-existing joint disease, immune-compromised condition like diabetes mellitus, using of glucocorticoid, HIV, or other immune-suppressive medications, and in patient who is or intravenous drug abuser. The most common routes of infection in septic arthritis usually hematogenous, by spreading of the organism through bacteremic blood infection from site away from the joint, usually skin or upper respiratory tract. How patients with septic arthritis presented to medical attention? Usually patients start developing acute monoarthritis associated with systemic non-specific symptoms such as fever, malaise. The patient start developing joint swelling, pain, hotness, and the pain characteristically occur both on passive and active movement. On examination, we will see obvious joint swelling from joint effusion. There will be redness, hotness, and severe tenderness on joint movement. In adults, the most common organism responsible for septic arthritis is methicillin-sensitive Staph aureus, but in young who is sexually active, gonococcal gonorrhea should be put in mind. In elderly or those with immune-compromised condition or intravenous drug abuser, gram-negative organism and streptococci is another possible infectious agent. How we manage patients with septic arthritis? Before we managing patients with septic arthritis, almost always you need to think about septic arthritis when you are dealing with acute monoarthritis. So the first differential diagnosis in any patient presented with acute monoarthritis is septic arthritis till proof otherwise. So how we manage patients with suspected septic arthritis? First and of all is to admit all patients to the hospital. Second, rapid urgent investigation in form of joint aspiration, and the aspirated fluid should be sent for white BC and differential, gram stain and culture sensitivity, preferably the aspirate done under imaging such as joint ultrasound. Also, we need to send some blood investigation in form of culture and sensitivity and routine biochemistry test and hematology and inflammatory marker. Looking for the underlying infectious process, which we said previously, it's usually in other site, so one may have to do sputum culture, urine culture, or high vaginal swab culture, looking for process like pelvic inflammatory disease in female, urethritis in male, or upper respiratory tract infection in both sex. After culture has been secured and aspirated fluid has been done, antibiotic therapy should be started immediately. So we said the most common organism is methicillin-sensitive Staph aureus. So the treatment of choice will be anti-staphylococcus. Penicillin in form of flucloxacillin is the treatment of choice. But if the patient is penicillin allergic, then we should try either clindamycin or vancomycin. Lastly, if a patient has risk factor for gram-negative organism like elderly male with recurrent UTI or patient with intravenous drug abuser, intravenous gentamicin to cover the gram-negative organism should be added to the empirical therapy. Symptomatic treatment in form of analgesia, antibiotic should be considered to relieve the pain. Also, one can consider local ice pack. If the joint swelling is severe, joint aspirate for therapeutic purpose 1-3 times daily until dryness of the joint can be considered. And don't forget to arrange for physiotherapy to prevent muscle wasting around the joint because of the disuse or misuse of the joints. Another infectious agent should be discussed is viral hepatitis, which is aseptic arthritis. Before we talking about septic, which is bacterial. Now aseptic, which is viral. Viral hepatitis usually presented in rheumatoid-like picture as acute polyarthritis, usually following a febrile illness. Some of patients has generalized skin rash. In the majority of patients, the arthritis is self-limited and has complete resolve within 4 to 6 weeks. With human parvovirus B19 responsible for the majority of cases, but unlike the infection when occur in children, the skin manifestation usually mild or there is no skin manifestation at all. So we should not find the slab cheek facial rash in all adults infected with parvovirus B19. Other infectious agents that lead to viral hepatitis need to be considered, including hepatitis B, hepatitis C, rubella, and infection with HIV virus. In all of the cases, management is usually symptomatic with non-steroidal anti-inflammatory drugs or other analgesia is the treatment of choice. Thank you very much.